If you're checking this out for the first time, this Keith RN live stream is to support and serve the needs of nurse educators such as yourself who are in the trenches, in the heat of battle, so that you are empowered to better prepare your graduates for practice as well as the NCLEX with practical strategies to develop clinical judgment. And if we haven't met, my name is Keith. I'm the founder of Keith RN, and really the founder of this, of what I do over 11 years ago, is my passion to serve the needs of educators by providing you with the best possible tools, resources, strategies, as well as making educational best practices practical so you can easily implement, if there is such a word in nursing education, needed change. And so I'd love to know who's out there tonight. If you're joining us on this beautiful summer has begun. I think yesterday was the first day of summer, so I hope you're enjoying your summer. And I would just love to have you put your name in the chat. Let me know who's out there tonight. Let us know where you're from. And it's really a pleasure to have you with us tonight. I also want to let you know that our topic today is really, really awesome. It is going to be on the topic of improving clinical judgment in the traditional classroom, how we can innovate classroom learning. And I've got two faculty from Endicott College in Beverly, Massachusetts, who are joining us tonight. And Josie and Liz, they also wrote an incredible blog article for Keith RN, as well as a video that's embedded in that. And I just posted that video, that blog today. So I've got, for those of you that are more, kind of got the auditory learners, we've got the visual learners. If you like to read, the blog will be a great help for you. So you know what, you can kind of make a note of that and put that to good use. And so I just want to welcome some of the people who are joining us. Cindy and Hazel from Minnesota. Great to have you, Hazel. I'm also a Minnesotan, coming at you from the northern suburbs of Minneapolis. We got Heidi with us, Holly, Dr. Taylor from Jacksonville, Florida, and Julia in Orange County, where I think the sun always shines, and Aaron, Tina, we've got Del Marie and Lisa from California. I got people coast to coast. And as you know, Liz and Josie are coming at us from Massachusetts. And so it's a pleasure to have them with us tonight. Just want to let you know that, last month, I do these live streams about every month. It was about 6 weeks ago. And I had a really valuable discussion with faculty from Mid-Michigan College on how to innovate classroom teaching with an oral care plan. How would you like to eliminate or decrease the infobesity in your clinical paperwork? Well, you know what? We have got, they also did a blog article that's posted on Keith RN. So if you missed it, I want you to know that if you want to decrease clinical paperwork, that is a great place to go. And I also want you to know that every one of these live streams, if you're more of a video person, you can watch them on my YouTube channel, Think Like a Nurse. And I would encourage you to subscribe to that. And this is the link to that. And all of these YouTube lives, the one on oral care plannings, everyone's about 45 to 60 minutes, but there's a lot of engagement. You can scroll through it. The bottom line is it's there for you. So it's a free resource. And I've got dozens of live streams we've done over the last 3 years. Been blessed to do that and so excited to just share some real practical strategies for all of you to strengthen clinical teaching as well as in the classroom. Let me just give you some food for thought. As we look at, the summer, for me, I have always been a type A driven dude who doesn't know when to rest. And if you're looking for a resource, a book to sit by the lake, the ocean, if you're on the coasts, I've got a book I want to commend to you that has really ministered to me over the years. And basically, it's a book called Margin. And the subtitle is this: Restoring Emotional, Physical, Financial, and Time Reserves to Overloaded Lives. And, for all of us in nursing education, what we basically are consistently struggling with just the platter and the workload that we have. And, when you look at a book, like I got Benner's Educating Nurses, you look at the inside, look at the edges of each page. What do you notice? There's margin. And, margin is really, in essence, the blank space that is on each side of the page. And it's there for a reason, to give your eyes a break And if that page just kept, those words kept going from edge to edge, it would get weary to read and you would put it down. And in the same way, we are finite human beings and we need to know our limits. We need to make it a practice to integrate margin into your mornings where you pause, reflect, meditate, pray, and just be still so that you can get the energy and the strength you need for that day. And then close the day like the other side of the page with that needed margin. And so I just want to encourage you all to find that quiet place in the morning, in the evenings, because if you keep going on the gerbil wheel, you know what, we're going to burn out and will be of no use to our students. And I just want to encourage you all to embrace the principle of margin, as well as reading that book. If you're looking for a summer read, that's on Amazon. That's the link. I hope you check it out. And so anyways, just wanted to encourage you with that reflection. And with that, I want to introduce my guest tonight. I've been blessed to travel around the country, speaking at conferences, as well as just attending as a vendor for Keith RN. And back I think it was April, I was at the ATI Summit in San Antonio as a vendor, and love the posters because there's all kinds of innovative ideas. Every educator is creative. And I love to see the research and the topics. And I came across this poster from Josie and Liz that are my guests tonight on the topic of developing clinical judgment in the classroom using video case studies and problem recognition emphasis. Because one of the challenges and one of the real kind of things we need to always remember is a problem in practice settings is failure to rescue, which is basically when a nurse fails to recognize or fails to notice, using Tanner's language, that there's a problem and they don't recognize it until it's too late. And you can have an adverse outcome or even a patient death. And that's something that many of us have seen or experienced firsthand. And like any clinical judgment skill, it needs to be practiced, problem recognition skills. And so I'm really pleased to introduce Liz Landers and Josie Dawes. I'm going to bring you on. I'm going to introduce you both, coming to us from Beverly, Massachusetts. Liz and Josie are both professors of nursing at Endicott College in Beverly, Massachusetts, as well as nurses who have not left the bedside and continue to practice in the clinical setting. Combined, they have over 30 years of practice experience, including various roles and settings in both clinical and academic leadership. But in the classroom, they found a passion for teaching clinical judgment and are currently engaged in research on strategies that promote clinical reasoning and reliable instruments to capture the complex cognitive processes that define nursing practice and to ensure that our graduates are practice ready. So I just want to thank you both, Liz and Josie, for joining us today. And so glad that you're here. And I just, wanted to get started with just kind of, every one of us has a journey. And like, why are you a nurse? And how did you make that transition to nursing education? So I want to just, briefly share your journey and your story, because now you're both basically pursuing your doctorates at Endicott College, where you teach. And would just love to know just kind of that journey and that story. And then we'll jump right in and empower the faculty that are watching tonight. We've got a great audience tonight. So thank you so much for those that are attending to watch live, because you get the privilege of asking questions. So as we engage and we have a conversation, I want you to put your questions in the chat as those that are watching tonight, and we'll get to everyone before we call it a night. So Liz and Josie, the floor is yours. Share your story. Who'd like to start?
So I'll go first. I was. I'm I'm sorry. I'm Liz. I know. I'm Liz. So my transition from practicing bedside nurse solely to doing the combination of nursing education and also practicing really kind of came because I realized that probably 90% of what I was doing in clinical practice was education. It was educating, colleagues, it was, patients and families. And I just felt it was just a really rewarding and exciting thing to go through that process. So then, the idea of I can help this one patient, which is wonderful, and I'll continue to do that. And I can also teach a student who's going to then go on and take care of, thousands of patients over their career. So I think the transition for me felt pretty seamless, but I love the fact that I've always been able to continue to practice at the bedside while also doing education full time.
And where's your most recent settings, Liz? Where are you currently? What is your? Where's your most current experience?
My most current practice experience.
Yeah.
So most recently, I actually just had a position shift. So I was most recently at Lowell General Hospital in Lowell, Mass, working on their step down unit, and I just transitioned to Beverly Hospital, which is right around the corner from Endicott and has an excellent practice partnership with us. So now I'm doing per diem at Beverly Hospital.
Okay, awesome. And what about you, Liz? Or Josie, I should say.
Josie, yep.
Yeah.
Well, I have more recently made the transition to more full-time faculty. I've taught as an adjunct faculty for quite a while. And what I realized working as an adjunct faculty as well as practicing full-time was that I really also loved teaching. And when I really thought about my impact on patients and patient care, I felt like I could have an even bigger impact on more patients by teaching other people how to do this hard work. And especially post-pandemic, when I thought about what sort of fills my cup and what makes me feel good, it's the rewarding feeling that I get from being able to teach other people how to make an impact on the healthcare environment. And so that sort of pushed me full time into academia while still maintaining a per diem practice. Primarily right now I'm working per diem as a nursing supervisor at two different hospitals near us here at the college. And I'm getting a bird's eye view of a whole lot of different specialties, which has been really fun. So,
And my question for you both is that how are you able to maintain some degree of currency in practice, as well as teaching full time and even pursuing your doctorate, and the time and the bandwidth that takes? And so how much are you able to actually work per diem, which is a wonderful win, because as you stay current in practice, your students recognize the difference. And I think it's essential that we really, as much as we're able, but sometimes, our culture doesn't support that, or our time schedule doesn't support it. So I'm just curious, how have you both been able to do that successfully and still continue your teaching schedule in academia?
Can I answer that question first? Because I will be honest, it's very difficult. But currently on the lower half of the screen here, I'm wearing scrubs. And I'm going in, when we wrap up, I'm heading in for a night shift. So I think the answer to that is, squeezing it in whenever we can.
Yeah. So how often do you work practically, Josie? Is that like one shift a month, twice a month? What's your goal?
It varies. So when I'm teaching a full course load during, from September to May, I've been doing one shift a month. But this summer, while have a little more free time, I've been working about 3 shifts a week.
Okay, great. And what about you, Liz?
Yeah, so same for me. I mean, when kind of the way the academic calendar works is that you're afforded sometimes where it gets quieter and you can work more, and then also times of the year where it's really difficult to do more than once or twice a month. But one thing that I have been lucky with, and also I feel like I advocate for, is that I've never had an education position where I wasn't completely transparent about how important it is for me to continue to practice clinically. And I think that I'm finding now that there is a lot more support for that in higher ed, and I'm not sure if it's because of the shortage in nursing faculty and we have a little bit more of a voice in what our workload looks like. But I just encourage anybody who wants to stay current and practice just to advocate for that time. And other disciplines have days that they're given for research and things like that. I mean, this is my research. My research is going out there and taking care of patients and seeing what's different. But I do think it kind of falls on us to sort of advocate for that balance, because we as a profession tend to take on too much, and I've been definitely guilty of that. So I think that, it's about knowing what your limits are, but also being clear about what you need.
And you bring up an excellent point, Liz, because in the medical education, the professors there are literally, it's a requirement to stay current in practice or research, but they get credit for it. It's basically part of their overall academic workload. And that's the cultural change that we don't have in nursing education that we need to advocate for at some level. And again, it's not always going to be responded to, but I think that's one important aspect we need to really do to transform the way we teach. Because my next question is it kind of relates to that. Would you agree or disagree that your currency in practice and having that lens of practice, which I too was blessed to have, working Baylor weekends, working 12-hour night shifts, Friday, Saturday, transition Sunday, teach Monday, rinse, cycle, repeat every week. Well, I'm getting old and I'm getting gray, but in the day I love doing it because I love to teach. But my point is, has that lens of currency of practice influenced the way that you're teaching in the classroom and what we're going to talk about tonight?
Yeah, absolutely. And I think one of obviously in the last 3 years, it's been more apparent than ever before that, being out there and kind of seeing what the frontline workers were experiencing was really important, to then be able to go back and talk to the students about what we were seeing and concerns that we had and how our profession as a whole was shifting. I also think it's really important because it helps us gain credibility with our students, especially right now where we're we're talking so much about burnout and about taking care of yourself and resiliency and supporting the profession, to not sort of be in it ourselves and experiencing that makes what we say, I don't think as impactful. But in terms of like the clinical judgment piece of what we're teaching in the classroom, the nice part about being out there is that we are not just out there taking care of patients, we're out there working with novices and we're seeing their struggles and we're seeing that disconnect between, what they were experiencing in school. And I graduated, I was told I was ready to be a nurse by this national exam, and then here I am having no idea what I'm doing, and it's this culture shock, and we see that all the time. So we're able to take those experiences that we recognize are particularly challenging for our novices and bring them to the classroom and use them as sort of exemplars. Like, let's do this case study because I've seen a trend of something like respiratory distress is something that's really scary for these students, and it happens all the time. So how can we get them to the point where they're able to notice, those subtle changes in a patient early on, so they don't feel like they're underwater, and also self-conscious about the fact that they didn't notice it, and now they're afraid of speaking up and advocating for their learning needs because they're in such a busy environment. So I think it's really given us a lot of content to work with that's very realistic for the students, and I think that they appreciate that for sure.
And so tell me your journey, because you basically went, I'd like to know kind of, how you moved from traditional teaching to really doing some innovative work with video case studies, problem recognition, clinical judgment. And so we're going to dig into that next. But I just like to kind of get a sense as far as, because many faculty struggle to make learning active and meaningful active learning. And what I mean by that is that it's not necessarily games, but it's really case-based, clinical-based realities that we want to prepare our graduates for. And, kind of like, what was that transition or journey to go from, the traditional death by PowerPoint to where you're at? What were some mile markers or some things that you learned that would really help those that are listening and watching this, either live or the recording, to kind of like some things that you learned in that journey to make learning meaningful and active, with an emphasis on clinical judgment versus what you were doing when you first started, which we all start from ground zero and we always can improve. And so I just love to know just briefly what that journey looked like before we dig in.
Well, I think for starters, I think to sort of like dovetail on what Liz was saying about the relevance of this practice experience, one of the things that we were noticing was that all too often, nursing students are searching for the right answer. And what we see happening in practice is that there's not always a right answer. Sometimes it's just you need to feel comfortable doing something. And so one of the things for us with this sort of teaching model was we needed to be very comfortable with the ambiguity of the situation. And so we needed to be able to feel comfortable leading the classroom in whatever direction these students were going to take us. So we ourselves needed to be very flexible in our thinking and very open to moving the situation wherever the students were going to go. There was one day that we did not plan forward at all, but the students picked the wrong action, and the case went into a cardiac arrest, and we went there. And
just like simulation, you're kind of bringing that sim kind of vibe where patient's dead or is going to go into a bad outcome because of a choice you made. You're kind of bringing that same salience into the classroom, but you've got to be comfortable with the ambiguity. And, Hazel, had a comment that she shared that I think is great, is that, students aren't comfortable with the gray zones or that lack that ambiguity. But would you also say that faculty, what I hear you saying is that we need to be comfortable not being in control of our classroom and being that sage on the stage. We've got to be willing to kind of think like an ER nurse and just kind of be flexible. Whatever the cat drags in, we're ready for it.
Right. Yeah. And I think that that's something like Hazel said about the gray zones. Josie and I have really kind of been very transparent with our students from day one that, we are not going to have all the answers. We are, excellent practitioners. We are what we consider to be good educators, but we're not going to have all the answers, but we are going to help them put together the tools to figure things out. And what they're going to learn in nursing school is a small fraction of what they're going to learn when they're out there practicing. And the goal here is to get them more comfortable in those gray areas so that when they do enter into practice, they enter into it like an open book. They're ready to learn, absorb everything that's going on around them and build that intuition over time, instead of just walking in and thinking that they're, I passed my boards, I'm ready to be a nurse. And I think that, again, back to maintaining our practice, I feel like I learn something every time I work. Things are changing so fast. Like I said, the pandemic is a perfect example. We're doing things now that I had maybe seen once, before the pandemic hit, and now all of a sudden we're seeing practices that we're doing all the time. And I think that the students need to trust us, and the only way to do that is to get ourselves to their level. And what I mean is, instead of having them fear us and want to make us happy and want to impress us with their knowledge, they need to recognize us as being, sort of maybe guides, but certainly going on this journey with them, because that is going to bring them out of their shell and take students that are reluctant to speak up or reluctant to engage in active learning to kind of come out of their shell and participate. Because if anybody is striving for an active classroom, it really takes a lot of buy-in from the students, and students they're all over the map when it comes to that. There's the ones who yell out the answer before you even finish asking the question, and then there's the ones who have probably bought all their Christmas presents off of Amazon by the end of September and in the middle of your class. So how do you get all of them onto the same page and engaged in an activity? And it really has to do with making it interesting and making it fun, and kind of the things that drew us to nursing in the first place, the figuring it out and the critical thinking and the I wonder what will happen if this happens. Or I always tell students it's like having a crystal ball. You most of what we do is anticipating all the terrible things and then keeping them from happening. So
the worst possible, hope it doesn't develop, but you're looking for it.
Yeah, and I think that they like that. They like that troubleshooting and problem solving piece of things. And that, I think, is where the best learning happens, because they pull it forward. And maybe we just did a whole 2-hour simulation that covers, the basics of infection control, but they're not spitting out flashcards with different types of precautions, transmission-based precautions on them. They're actually using it and remembering it because it becomes so much more meaningful to them after they've gone through that process of sometimes making incorrect decisions, sometimes being corrected by their colleagues. Sometimes we'll say, "Are you sure you want to do that?" Like, all right, here we go. And, and I think that and they enjoy that process.
Yeah. Well, let's basically, let's set the stage. What semester are you teaching? You're in a baccalaureate program. What semester? What's the course? And then we're going to break down kind of how you are teaching that course, bringing video vignettes of case-based learning with your strategy. So kind of what you had on your poster, I want you to kind of just verbally and kind of just walk us through it. So what level? And kind of then maybe share how we could, at the very beginning, how any educator could do it for any level. So what was your level? So just kind of let's bring us down to ground zero. And what was that looking like?
Well, so these are, in this course that we're teaching this model in, these are junior level students. So they've had a med-surg course in the past, so they have some basic background knowledge. And in our program, we have, the course is actually titled Clinical Judgment. So it's a course that meets face-to-face for 2 hours each week. And so the format is consistent for them, but they're junior level students, and so they have a little bit of background coming in.
Okay, so basically like a traditional, like an ADN program, be like semester 2, maybe semester 3, because if you had a primary med surg, fundamentals med surg, advanced med surg, probably in that semester 3-ish range. But a topic on clinical judgment, which is a great course. We don't have enough of those in our curriculum. I love the topic. And so let's just break it down for us and tell us how you operationalized this really powerful active learning strategy.
Sure. So I think we were fortunate that the class is titled Clinical Judgment, and we were able to kind of do. it was a lucky thing that happened, but I do feel like this is the structure of this course would work in any class, any topic, any specialty, any class at all. So although we had junior students in clinical judgment, I think it would translate well to an activity at least in any other class too. So what we did was, as Josie said, we had them in front of us for 2 hours once a week. So that did require us to put some work on them to come to class prepared to make the best use out of that time. So what we did was we started with a video report of either Josie or myself playing the role of the nurse, handing a patient off to the students, and they watched that on their own outside of class. Based on the report, we asked them to basically to notice some concerns based on the report, cluster some symptoms together, or some findings together that start to paint a picture of what they're expecting to see when they encounter the patient. We assign them some research to do, just basically reminding themselves of some basic medications, some diagnoses, some diagnostic testing, and it totaled out to maybe an hour worth of prep work before coming to class, which we found the students consistently did. And they did it because if they did not do it, the class was just not enjoyable for them at all. They came in and they really couldn't meaningfully participate, so it ended up kind of policing itself. Came to class after having done that pre-work, and right when they walk in, the scenario starts. And what we did was we used some kind of established products, video case studies through ATI, some Lippincott textbook products. There's a lot of really good video case studies out there, but what we struggled with was that they didn't work for us kind of right out of the box. We needed to mess with them a little bit in order to get the activity to work for us. So we basically took these videos and kind of spliced them down into little vignettes so that we could control what happened between the scenes. So we didn't just want to have a patient go into a fluid volume overload situation. We wanted the patient to do that, but maybe also the patient falls on the ground, or maybe also the patient develops a pulmonary embolism and has to be started on anticoagulation. We wanted to kind of add more into it because we don't have a respiratory patient, a cardiac patient. We have patients who a million different things happen to them from the time they arrive until the time they go home. So we wanted to have that ability to maneuver. So we kind of spliced up the video, showed little clips, and then we introduced what we called clinical curveballs within the scenario, where we threw, a potassium of 6.0 or something to change the scenario and make them reprioritize, and also make them, we really focused on noticing and say, okay, so what other pieces of additional information would you want to look at based on this finding? What's relevant here? What additional data is going to help you make a good action? So we put them into groups. We allowed them to collaborate with each other. We let each group make the decision to move the case forward. We went around the room. Everybody participated, and they were allowed to speak up if they didn't agree and give their rationale. But the point was, we wanted them to have the ability to. I said to the class before, if you tell me that you want to give this patient a puppy, I will support you if you can give me a really good rationale for why that puppy is going to make a difference and how you came to that conclusion. So they got really comfortable saying, what they thought would be a good action and then justifying it. So I think that at the end of the scenario, however it ended, from one class to another, it could be completely different. We taught 2 sections of it back to back last fall, and what the first group did and what the second group did was sometimes like night and day. Then the last part was, once class was over, we had them do a reflection on action discussion post. So they had to really think about what went well, what would they do differently next time, what are they taking away from it? And that's really where we saw the most learning happening. They were really kind of internalizing some of the incorrect decisions that they made, and really kind of appropriately backtracking and modifying what happened in a way that would have resulted in a better outcome. And we thought that was wonderful. But also what we were seeing in these reflection on action posts were they were using them as sort of almost like a journal to talk about how their confidence was growing. And that was actually where we got the idea for presenting this, because we were seeing this change in them that was so rewarding for us. And in the population of students that we noticed the biggest difference were the ones that we know they work hard, we know they clock the hours, they care so much, but they're just not getting the grades that they want. So we found that those students really shine. They were able to articulate their decisions, their rationales. They were able to put the pieces together. They came up with really great patient-centered interventions, because they were not doing it in the form of an objective test where it was like, choose the right answer, choose the best answer. They were able to just kind of think their way through stuff, which is really what we wanted to see. So that group of students was really where we noticed the biggest change from the beginning to the end.
And so the language that I hear you using, Liz, what are you noticing? Interpreting the meaning, the responding, the reflecting in action, reflecting on action. For those of you that are familiar with Tanner's clinical judgment model, that is what you're operationalizing in your classroom. Am I correct with that assumption?
Yep, correct. Yeah, and we weren't quiet about it either. We presented Tanner's model to them on day one, and then we made sure that we used the language, because we wanted them to recognize what they were doing and why it was so important.
So this is the kind of the dynamic in nursing education that I'd love to get your feedback on. There are a lot of programs that, though there's no evidence to support it, are advocating and using the NCSBN clinical judgment model and its 6 steps to teach students clinical judgment, using the language of the NCSBN model as well, when it's an evaluation model. And you're using Tanner's. I'd like to know why.
Well, Tanner's model is tangible. It's something that students can grasp, and the NCSBN model is what its intention was, an assessment model. It was for educators to be able to use that as a way to design curriculum and assess students around that. It's not language. It's not able to be grasped by a novice student doesn't understand that piece of it. That's not what it's for. Tanner's model is the way a nurse thinks, and Tanner's writing really supports all of that.
Yeah, and we've talked with each other and with the students that, I've been, in the entire time I've been an educator, I have been just, I can't think of the right adjective here, but about to describe my feelings towards the nursing process. And what I mean is it just felt so, empty when compared to what I felt I was doing in practice, the thinking that I was doing in practice. And this is the first time that I have really felt like somebody has captured that sort of like intuitive process that we do, and that very invisible internal process that we go through all the time with every patient encounter. And I think that students, I almost feel like if somebody had used this with me when I was in nursing school, it would have been this aha moment, like, oh, I get it. That makes sense to me now. I understand why we, have to do things the way that we do. And I wish that had been the case for me, because it wasn't. And I really do think the students understand it and it makes sense to them. And it also makes the process of getting them on board of what we're trying to do, it makes it a lot easier.
The words that we've used with each other are that what Tanner's model does is it really makes this implicit work of nursing, it makes it explicit, and it gives us a tool that we can use to make something that seemed imaginary and invisible something that we can say, this is what it is. This is what it is you need to do.
Yes, and when you look at Tanner's model, and I don't have the link with me right here to put on the screen, but if somebody could go to Chris Tanner, Thinking Like a Nurse 2006 PDF, pop it in the chat, please. Because Tanner's framework, what the background of that is that it was synthesis of almost 200 nursing articles that Tanner literally did a systematic review of the articles of clinical judgment coming from practice in nursing. And it's a practice-based, practice-informed, evidence and research-based framework of clinical judgment. So it came from practice. And that's why I think, the things that you said, both Josie and Liz, resonate, because it has that salience of just real world practice, the language of practice. What are you noticing? What does it mean? How do you respond? I'd like you to clarify, when you talk about reflecting on action, some of educators who may not be familiar with Tanner's, which again, we need to be, but define that. And I assume that was a written activity that your students did. So it's kind of like a student journaling with a structured reflective journal, if I understand your ending correctly. Is that right, Liz?
Yeah, yeah, that's really what it was. Reflecting on action is sort of this like summative evaluation of what happened, what went well, what didn't go well, what would you do differently next time, were the 3 prompts that we used. And reflecting in action involves, sort of basically seeing if what you're doing is working in the moment and doing further assessment evaluation. But this is more of a almost like a debrief, like looking at the situation in totality and deciding, where should I go from here? Was that a success? Was it not a success? What kept it from being, the perfect outcome? With these activities for these students, there were a lot to choose from because they sometimes were, way off the mark. And like I said, we kind of made it a point to allow it to happen because that's where these kind of learning moments came. And we found that out of the students in the class, we would get a whole bunch of very different foci from the students. They would pick up on very different things that they took away from the sim, which just gave us the impression that it wasn't so, they weren't being spoon-fed. It wasn't such a deliberate activity that they had one thing that they walked away from. It really was more about they walked away from it reflecting on the gap in their own knowledge. They identified the thing that they didn't already know, the thing that they need to work on and get more comfortable with. And so it became very student focused.
And I think the other big piece about that is that Tanner's model really supports the idea that the nurse grows in their clinical judgment by reflecting on action. I mean, that's the key piece. And I think one of the things that we really want to instill in the students in going through this exercise is that reflecting on action is a skill that you're going to take with you throughout your career. And so this is how you'll continue to grow. And so if you have that capability to critique yourself in a constructive way, then you're going to keep growing in your practice.
Right. And, that's a powerful, reflective journaling. That's the I think one of the values of Tanner's framework is that it understands the value of not just evaluating like nursing process, it's evaluating the patient, but then reflecting deeply on those, on your judgments, why you did that. Was it the best decision? That's how you grow in clinical judgment as a student or novice nurse. So reflecting on action is something we must incorporate in our nursing programs, in the classroom, in our clinical post-conference, in simulation. Threading that reflection is going to strengthen and develop clinical judgment. And I think the classroom is a wonderful opportunity just to enhance it. The more you do it, the more the better the development of judgment is going to be. So I love that. So thank you for sharing that. We do have a question from Pam, and I want to just open this up. As Liz and Josie have shared, if you have specific questions about, how you can operationalize this, or just as it relates to the things that they did, please put it in the chat. We'll get to it before the end of the session. But Pam asked the question, how many students do you have in each class? And I'm kind of curious, how big were your small groups? So what was the size of your groups that you broke them into? And how did that dance look like as you interacted with the groups? And so just give us some background on that.
So our class sizes were around 30. I think the most were maybe 33 or 34. But I feel like we probably could have been effective with this up with higher numbers than that. It just was a matter of making sure there were enough decision points to keep the class moving and having everybody participate. The class groups were usually 4 students in a group. While, in order to have everybody sort of collaborating, if there was a group that was responsible for the next decision point, they were discussing it amongst themselves, and they were going to be the final say in what happens. But all the other groups were also at that point discussing amongst themselves, because if once they made the decision, we would open it up to the class, and then other people could agree, disagree, share, a contradictory view, and a rationale for it. So every decision point started with a small group discussion, then became a class discussion, but ultimately one of the groups was responsible for making the final decision. And we just sort of were there to facilitate, the movement of the case.
One of the things that became, that just sort of happened on its own, we noticed that groups were talking amongst themselves because they were engaged in the actual outcome. So groups were not shy about speaking up and saying, we disagree with what this group wants to do, and here's why. And we thought that was great. We really encouraged that discussion among the groups, and even asked for feedback at times, because we really wanted to model to them that teamwork and collaborating with one another is a really useful skill.
Absolutely.
And so that's something that we should all start practicing.
And so you're bringing in, better in educating nurses. She said one of the paradigm shifts we must do to transform nursing is basically bringing clinical realities to class and emphasizing clinical reasoning. And that's exactly what you're both doing, and I love that strategy. One of the questions I do have, though, that I have, that is, there's a lot more written case studies in the marketplace. I've written many of my own, and there's case study workbooks, etc. Can you, when you look at how you can adapt your strategy, I'd love your thoughts on basically taking like a written case study, whether it be one of a Keith RN or anything in a workbook that you could, how could a written case study be adapted? Because those are a lot easier to find than than a video vignette from wherever. Those are a little bit more, that's a little bit more challenging. So I'd love your thoughts, because that's a little easier to use for educators. And I'm just curious, could you walk us through how you could, and just in principle, using a written unfolding case study to kind of align in principle with some of the interactivity that you're doing with this strategy?
Well, no, it's funny because we were actually just talking about this, and we think it very easily could be done with a written case study. I think the formatting of that would need to look something almost like I envision it, like a choose your own adventure type book. So you would have your scenes set similar to the way we have these video vignettes ready to go.
The opening scenario presenting that initial, the stage.
Yeah, the scenes are there, but there needs to be enough wiggle room in between the scenes to be able to let the students to drive that.
Yeah, and I think that you could do, I mean, if you wanted to do it very simply, you could just create, some sort of presentation where you break the case up into short little pieces of information as the situation unfolds, present the scenario at the decision point, have the students collaborate on what to do next, and then again, you have to, that's when you sort of have to ad lib the in between, which is what we did with the videos too. I mean, we didn't have every scenario set up in a video form to present based on what they decided to do, but that was where we had to be comfortable enough to respond to the situation. And sometimes it involved pulling them back into where we needed them to be. But you could also do it with the written case studies if you wanted to turn it into a video. You could do it as just a nurse giving a report. We don't need all this high fidelity simulation equipment. Right. Sometimes it could just be me dressed up in scrubs and a stethoscope around my neck and say, I'm giving you a report on this patient. I'm reporting a change on this patient. I'm here to accept your patient who you're transferring to the ICU, and move the patient along in that way so that they're actually getting reports that are maybe missing information, reports that are, reports that are maybe providing some information that's not necessarily correct, and getting them to pick up on, that nurse didn't give us any information about this patient's mental status, or this patient has a hip fracture and she didn't say anything about peripheral pulses and that affects extremity. So getting them to sort of pick up on the things that are also missing is a great learning opportunity too. But you can do that with any written case study.
And what I really liked what you added that isn't always in a written case study or vignette are the curveballs. Is that now the temperature is this, now the heart rate is this, now the lab is this, and what does that mean? Because now you have to not only notice it as obvious, but to interpret the meaning of a potassium of 6.0. Josie, like you shared earlier, and then what does that mean? How does the nurse respond? And what is the implications of that with the plan of care? Right. I love that because that's practice. And so it's kind of like looking at the level you're teaching, the semester of the students, and basically adapting your curveballs and everything else, not to make it too complex, not to scare them, but to find, what are my objectives for this course, and aligning that with a case-based approach. That to me is your win.
Right.
How you could adapt this at any level, and what that would look like. As I look at this, when you look at the big picture, what are some of the big picture strategies? You talked about that, if we're going to be successful as educators, to implement change, meaningful active learning, what are those if you were just to kind of summarize some of the big picture things for us as educators? You mentioned one of them already, the importance of embracing ambiguity and not always being in control, and kind of just as an educator, as well as with the students. But what are some other principles that you have learned in your journey to help you be a more successful educator with active learning using this strategy, or really any other active learning case-based strategy? What are some of those thoughts? You shared them in the blog, and I'd love you to just kind of highlight those for us.
I think a big one is making the classroom a safe space where students are comfortable being wrong and they're comfortable sharing, even if the outcome's not perfect. And I think part of what we, I think where Josie and I kind of found ourselves on the same team when it came to education was that we both were very turned off by the idea of putting up these sort of like arbitrary walls between us and the students, and setting ourselves on like a different level than them, because I think that these students are, some of them are months away from being our colleagues in practice. So rather than sort of treating them, with this, I once heard an educator say something like respect is earned or something. And I thought to myself, is it really? Because I feel like it's just a fundamental right to be respected. And we should be respecting the students, not because, they earned our respect, but just because they're human beings worthy of respect. And I think that we need to treat our classroom in that way so that they see us as being their ally. They see us as being partners in their learning. And that breaks those walls down. It makes them comfortable talking to us about what their learning needs are. It makes them comfortable about telling us when they don't know an answer, because they know we're going to support them, just like we would support them if they were a novice nurse in practice and came to us for some help with a patient. I think that that's a really big thing in our classroom is breaking down those barriers and creating a very collaborative learning environment.
Yeah, we knew that in order for an active strategy like this to work, we definitely needed to have a trusting relationship with these students. And so creating that comfortable space for them was one of the most important things, I think. And being comfortable with being wrong, I think, is what really allowed them to, instead of searching for the right answer all the time, they were willing to just do something, which we also felt like was a really useful practice skill. I think that's one of the things that really goes into this failure to rescue idea, is that, sometimes a new nurse gets really stuck in, what do I do? Instead of, well, it doesn't matter right now, just do anything, get help, get, whatever it's going to be. So creating that safe space for them to say, well, it's okay if I'm wrong, at least I'm doing something, was really an important, useful life skill.
Yeah. And I love the term in the nursing literature. I don't know where I came across it, but intellectual humility. Where you just basically recognize, I don't always have to be right. I'm a student learner. And we don't, we just create that culture of intellectual humility. I love that term. It just resonates with me. And that's exactly what you're describing, Josie.
True.
A problem, though, that educators struggle with, including myself, when I was bringing my case-based active learning, is student resistance, student buy-in. And so, when you look at the journey, to get that buy-in, for my students, they saw the relevance over time that this was really translating into their clinical practice, and they saw the value, and the buy-in took time, and they saw the relevance. For you in your journey, what has been your experience to really strengthen and to promote student buy-in, so you really kind of create that culture? Yes, the trust is one aspect, but anything else that you would add that really could just be some practical strategies that would help any educator with any type of active learning? What is that, what did you do to kind of encourage or facilitate that buy-in?
Well, one thing that we have always exercised is full transparency with the students. I mean, they want to know why you're asking them to do what you're asking them to do, and in my mind, they have a right to know, and that keeps me honest with what I'm assigning. With it makes me more thoughtful about what I put together as pre-class assignments, post-class assignments. It takes some time, but what you want to make sure you're doing is respecting their time and effort. And they're smart. They know when they're doing busy work. They know when what they're working on, what they're completing, is not translating to a better understanding of the material. They know when an activity that they're doing feels to them to be very, it feels like busy work, and they'll say that, and we get very insulted by that term, busy work. But in reality, a lot of what we assign them, and they are, and if we're talking about preventing burnout in nurses and all of that, like, we need to be more thoughtful about the intellectual overload that these students are experiencing, and really put time and effort into respecting their time and the effort that they're putting into our class, and doing that by being thoughtful about what we ask them to do, and then also giving them good feedback. I mean, I don't assign anything to a student that I don't have the intention of reading and giving them feedback on, even if that feedback just involves a class discussion. about something, but they need to feel as though the effort that they're putting in is respected and heard. Don't give them a discussion post if you're not going to read the discussion post. A student loves it when you say in class, like, oh, Mary made this great comment in her discussion post. What do you all think about that? Because the student feels valued, and it makes them more, it incentivizes them to participate more because they know you're paying attention, and they know that whatever they're putting in, they're getting something out of.
I think the other big thing, and Liz and I talk about this part all the time, is that they see us enjoying this, and so we're modeling a joy in the profession of nursing. We're modeling a joy of and fulfillment in finding the right answer. I mean, to us, I think we both believe that this work, this thinking, this investigation that we do as nurses, this is what keeps practice exciting. This is the fun part. The fun part of my day is not checking the patient's vital signs or listening to their lungs. It's the figuring it out. And so when they see us enjoying that in the classroom and having fun with it, they want to get involved. Why are Liz and Josie having all the fun here? Let's do this too. So I think they want to emulate that. They see it being a positive thing, that working hard is what we're here for. And so I think that's a really important piece to keep them motivated too.
One question that I also had is that how are you evaluating your students with this active learning strategy? Because it seems rather ambiguous. You're doing small group work, they're doing reflections. And so I would just give me a concise, how are you evaluating your student performance and giving them a grade in a course like this?
Yeah, so we do award them credit or grades for completing the preparation work. One of the I didn't mention this before, but one of the steps of the preparation is a short quiz. It's 20 questions just to make sure that they did the research pieces, things like very straightforward questions, side effects of medications, nursing considerations, about therapeutic procedures, things like that. So that's part of it. We also gave them they take a formal midterm and final exam that is a case-based evolving scenario. They take care of one patient, and then another patient gets introduced, and it really is an exam that the attempt of this exam is to model what we do in the classroom, but have them do it alone so that we can really evaluate whether they are able to follow that process. We do it at the midterm, and then we do it at the final exam point. That makes up 50% of their grade. So it's a good chunk is made up of these objective exams. The students, we also evaluate their, not evaluate it so much as we also ask them to share their confidence level at different intervals in the semester, because we want to know whether or not, even if their grades aren't necessarily improving, like, are you getting more confident in participating? Are you getting more confident in taking a part in this activity? And we saw, the students overwhelmingly just shot up in terms of their confidence in the decision-making process. And the other piece that we look at is at the end of the semester, obviously the students complete evaluations. We use that qualitative data to kind of guide any changes we need to make, and the feedback that we get from the students, so we pull that forward and address anything. So the students are earning a grade based on exam performance. We model as many of the questions as we can off of the NGN, the next generation NCLEX exam, so they get more practice with those types of questions. But it kind of works great because that's already what we're sort of doing in the classroom, like relevant data versus irrelevant data. So all of those same formats of those questions are present in the classroom. So yeah, it's.
Got it. Well, in closing here, I'm going to basically share your email that you gave me permission to share. That for those of you that are watching this, or whether it be live or recorded, this is the email. It's a combined email. It'll go to both of them. And so I just want you to know that Elizabeth and Josephine at gmail.com, easy to remember. They'd love to hear from you. Their heart is like mine. They really want to serve and make a difference and empower other educators to just, make a needed change and make a difference. And so thank you so much, Liz and Josie. If you have, I just would like, in closing, just give us a final pearl. If there's like one pearl or principle that would encourage and empower educators in the big picture with what you've developed, or just in general, just a closing thought from each of you before we call it a night.
So I'm going to go first because I've been trying to find a way to say this, and now you're giving me the opportunity. But what I really encourage everybody to do, and I think that Keith RN platform is wonderful because we're not, Keith, you didn't reach out to us and say, show me your data, show me the hard numbers. I'm going to evaluate it and decide if this is an effective classroom strategy. I'll get back to you in 3 months and let you know. Maybe in 2026 it gets published. This is just us sharing what we think is wonderful and what works great for our students. And we hope that other educators take advantage of platforms like this to share even anecdotal stories of active learning strategies, things they're doing in the classroom that are creative, that students are enjoying, without the pressure that comes with a publication or writing, a manuscript. Because I feel like that's such a barrier to us disseminating these ideas. So anytime you have the chance to share something that you're doing, please share it with us. We love hearing, we want to get better at this, but share with each other and get it out there in any way that you can.
Yeah, I think I would agree. I think one of the things that we talked about actually as we were preparing to join in this conversation with you tonight is that we're excited to talk about this. We know that it's working great because we know that our students love it. But we're also excited to connect with all of you out there because, like Liz said, we know we have things to learn too from all of you. And I think that just like in practice, us as educators collaborating together, we're gonna be stronger when we're working with each other to learn from one another. So.
And what you shared is kind of a reflection of my heart, because I also have a blessed to be the admin for a Facebook group called Teachers Transforming Nursing Education. Over 15,000 nurse educators from around the world that can have access and exposure to a post that you could share about what you have done to strengthen and transform your learning, and that you can share with educators. And that's a wonderful outgrowth right there as well, that I would build on what Liz shared to basically get it out there, whatever that looks like. And that it's my privilege to have, and my pleasure to have that platform available to any educator. It is a closed group. If you're not a member currently, just make sure you answer the 3 questions. So I know you're not a spam and you're not a student, and you will be a part of that wonderful supportive community. So I want to thank Josie and Liz again. Next month on July 20th, 4 weeks from today, we'll be doing it on reverse case studies. And actually an educator from the Facebook group who did a wonderful post on using reverse case studies, which is creating a case study, having students create the case study, not you, is going to be our topic for next month in July. And so Josie and Liz, thank you again for just taking time out of your busy schedule. You girls are busy. And then, Josie, you're going to work tonight. So, my thoughts and prayers are with you. I'm making a good night. I hope you didn't get your power nap. You're still going to be safe. I hope I didn't keep you from that. But regardless, it's been a blessing. And thank you again for sharing, for serving, and for being an innovator. Because what you're doing is based on educational best practice, using Tanner's framework, active learning. You are building your strategies on the paradigm shifts Benner advocated 13 years ago. So this is bigger than just the 2 of you. You're building on a foundation, and you have done something innovative. And I just want to thank you for making a difference and being part of the needed change in nursing education. So thank you again. Thank you. Have a wonderful night. And thank you all for attending, and Godspeed, and have a wonderful summer. Take care.